Hello, and welcome to the Week 15 Lab recorded lecture. In this lecture, we'll discuss knee anatomy and positioning. So I'm going to start here in our Canvas Week 15 Lab page, and you can see that everything we're going to talk about today will be listed here for you. I also wanted you to remember that you only have 2 more weeks. So I know you're tired, I know this is hard, but hang in there and keep doing your best, okay? You can do it. So let's get started talking about the knee. The first thing that we would do if we were together is we would get out our bone boxes and we would label our bones. So I have provided a list of anatomy for you that I need you to be able to identify on the distal femur and the proximal tib fib. So please either label your skeleton at home, draw this anatomy and label it, or pull out the bone boxes when you attend open lab and label the bones. Please, please, please practice with this anatomy. All right, that's first. Next, here is the technique chart. And let's talk about the 6 projections that we're going to learn this week. Okay, so notice 4 projections will be done on the table using the table bucky. 1 projection will be done tabletop, and 1 projection will be done at the wall bucky. And we will certainly go through and look at all of these projections in X-ray and talk about what we're supposed to see, but this is a nice little introduction and overview. Notice the first 4 on the table bucky, or using the table bucky, should all be 10 by 12 with portrait collimation. The tabletop and the wall bucky projections should be 14 by 17 with landscape collimation. And the reason why is the top 4, we're looking at the affected knee. The last 2, the doctors like to see both knees for comparison. So that is why we're using a larger receptor. Notice your SID is 45 inches in our room using our Siemens equipment. Remember, some clinical sites may still be using 40 inches. Also notice you are centering at the knee joint. And remember, you find the patella, you find the apex or the bottom of the patella, and you put your finger there. Remember, we learned that with tib fib. That is the knee joint. So that is where you're centering, about a ½ inch below that patellar apex. Notice your techniques are pretty similar this week, and you just have a couple tube angles to remember. And we will talk about those tube angles when we look at our projections. You should be able to successfully complete these 6 projections in 15 minutes or less, and this assessment is worth 90 points. Next, I have provided the competency forms here for you, so you can look at those before you check off week 16 or while you're practicing. Those competency forms are there. They're also in your Google Drive. I shared them with you a while back. Okay, we're going to look at this PowerPoint together here in just a second, so I'm going to skip over that for a second and just point out that I did post the positioning videos from last year. So until we can be together and I can demonstrate this for you in person, please watch last year's videos so you at least have an idea of how the positioning should go. And down here at the bottom, if we scroll down, we do have some practice activities, and I'll certainly talk about those at the end of our video. And I'll post this recording here for you. So let's go back and look at this positioning PowerPoint. And we will talk about the 6 projections and what you are supposed to see in each of the correctly positioned projections. Let's start with the AP knee. So notice the patient in the image here is recumbent. You can do a knee on the table if it comes in through the emergency room and it was a fall, or you can do this standing. Many orthopedic surgeons like this projection done standing because they like to see how the joint handles the weight of the body. Oftentimes, if it's an orthopedic surgeon, we'll do this projection standing and bilateral as well so that they compare both knees, you know, the good knee and the bad knee. For our purposes in lab, we're going to pretend this came in through the ER and they can't stand, so we're going to do this on the table. We're going to use the table bucky because we need a grid with the knee. And I want you to use 10 by 12 portrait collimation because we should see, you know, some of the distal femur and some of the proximal tib fib. Remember, in our lab with our Siemens equipment, we're going to use 45 inches SID. Some departments may still be using 40 though, so just be flexible and know the SID at your clinical site. For a correctly positioned AP knee, you want to point the toes up at the ceiling and slightly, you know, rotate the leg 3 to 5 degrees medial. And the reason we do that is we want the line in between the epicondyles, which I'm pointing out here, we want that line or the interepicondylar line to be parallel to the image receptor. So very slight 3 to 5 degree medial rotation. Remember, we're centering about a ½ inch below the patellar apex. So find the apex, put your finger there. That's the knee joint. And we're using about 10 at 80. And again, that's going to vary depending on the size of your leg that you are imaging. So looking at this x-ray, first things first, I know this is a left knee because my fibula is a lateral structure, my tibia is a medial structure. So if this is hung correctly, this has got to be a left knee if I'm talking to my patient. Okay? How do I know this is an AP? There's a couple things you look for. First of all, look at the relationship between the tib fib. The proximal tib fib should be slightly superimposed. You can see that right here. And that's really anatomical position, slight superimposition of the proximal tib fib. The next thing you should look for is the patella and the position of the patella over the distal femur. In an AP, that patella, which you can see here, should be centered. And some patients, you'll see some variance where even though you have them positioned in an AP, their patella might be slightly off center, and that's just unique to that patient. Most patients in a true AP, the patella should be centered over the distal femur. So when you are evaluating a knee x-ray and trying to determine what position you're looking at, look at the tib-fib relationship and look at the patella. All right, beautiful. Let's look at one of our obliques. The medial oblique. This is a 45-degree medial oblique. And you can see from the picture here, you're simply rotating the whole leg in 45 degrees. Nice and easy, no big deal. You're still using table bucky, 10 by 12 portrait collimation, 45 inches SID. You're centering at the same spot, just below the patellar apex, using the same technique. Now again, how do we know we're correctly positioned? Well, in a correctly positioned medial oblique, you should see separation between the proximal tib fib. Now in this case, you don't see necessarily a ton of separation, but look at the difference between this and if we go back to our AP. Look at here, they're covering each other up. Here, they're not. There's separation there. That is an indication that the leg is rotated medially. The other thing that you look for is the position of the patella over the distal femur. In this case, the patella is pointing medially. That is how we know the foot is pointing medially. The patella kind of follows the foot, right? Which is kind of an easy way to think about it. My patella is pointing away from the fibula, so it's pointing medially. All right, nice and easy. Let's look at our lateral oblique. This is a 45-degree external or lateral oblique. All the same technical factors still apply. This time, how do we know we're correctly positioned? Look at my tib fib. When I roll my foot 45 degrees externally, my tib fib are completely superimposed. Also, look at the position of my patella. Now my patella is pointing laterally or away from the body. So again, you can tell that the foot is rotated laterally. Okay, I need you to be able to look at the medial oblique and look at the patella, look at the tib-fib relationship, and identify, oh yes, this is my medial oblique and this is my lateral oblique. So remember, look at your tib-fib and your patella to be able to tell the difference in your obliques. Okay, next, let's look at our lateral knee. This is a 90-degree lateral, and you can see here in the picture that we are rolling the patient onto their side. You can certainly do this standing as well. You just turn them 90 degrees. This is a medial to lateral projection. So, still using table bucky, still 10 by 12 portrait, 45 inches SID, still using 10 math at 80 kVp. Couple different things here. Notice the degree of flexion of the knee. You want to use about 20 to 30 degrees of flexion only. The more you flex the knee, the more it's going to draw this patella downward. And we want to avoid drawing the patella downward for a couple reasons. We want to make sure this joint space remains open in between the femur and the patella. And this isn't a very good example of that, but the more you flex the knee, it could cause that joint space to narrow. But also, if that patella were to have a fracture, if you pull that patella downward, it could separate the segments of the patella or separate those fractured fragments, you could say. So more flexion pulls the patella downward, possibly separating any fragments, and we want to avoid that. A lateral patella projection, interestingly, is different than a lateral knee, and you may find that in your Bontrager if you're doing some reading. A lateral patella projection, you're only flexing 5 to 10 degrees. So just please know that increased knee flexion will pull your patella downward, and we want to avoid that. Okay, so we're still centering at the knee joint, so about a ½ inch below the condyles here in this case. And, you know, certainly I would encourage you to still put your finger at the base of the, or excuse me, at the apex of the patella and center there. I think that's appropriate. Now we have to add a tube angle. And notice our tube angle is 5 to 7 degrees. Here's why we use the tube angle. In anatomical position, our medial condyle, and let me point out the condyles here for you. These are superimposed femoral condyles. The epicondyles, you really don't see them nicely in a lateral projection. They're approximately right here, kind of this more denser structure. But in a lateral knee, we're focused on the condyles. Okay. In anatomical position, the medial condyle sits 5 to 7 degrees lower than the lateral condyle. But when we look at a finished lateral knee x-ray, we want to see the condyles superimposed. In order to superimpose the femoral condyles, we have to compensate for the medial condyle being lower by throwing on a 5 to 7 degree tube angle. Now, we're going to talk a lot about femoral condyles here in a second because there are two different scenarios where your condyles could be not superimposed. One is you forget your tube angle, but two, it could be positioning related as well. And so we'll talk about that more in just a minute. How do we know we're correctly positioned in this projection? Well, I just talked about it. You should see your medial and lateral femoral condyles superimposed. You should also see the joint space open between the patella and the distal femur. Now in this case, this patient doesn't have a lot of joint space between their patella and distal femur, and that's okay. This is a really nice x-ray. You have 20 to 30 degree flexion between the femur and the tib fib, and your condyles are beautifully superimposed. One thing I want to add here, notice this picture here, how the good leg, the leg that we're not x-raying, is behind the patient. You will notice from my positioning videos, and I think you'll see this clinically as well, Oftentimes, it's helpful to bring the good leg in front of the leg you're x-raying. So have them cross that leg over. And the reason is it really helps to position that knee in a true lateral. It just for some reason, it really helps get the affected knee nice and lateral. So I just wanted to point that out in case that caused you any confusion when you watched my videos. Okay, so we've already said in a lateral knee, we want our condyles superimposed. Well, what happens when our condyles aren't superimposed? We have to know how to fix it, just like we have to know how to fix a rotated Y. So let's look at a couple examples. First, let's talk about an under-rotated knee. Now, in this projection, we're assuming a correct tube angle, 5 to 7 degrees cephalic, okay? When you look at your x-rays, the first place your eye should go is your condyles. When you look at your lateral knee x-rays, the first place you should look is your condyles. I can see here's one condyle here, and here is one condyle here. They are clearly not superimposed. So if I use the correct tube angle, then my problem is positioning. So I have to know how to fix this. I have to know, did I turn them too much or not enough? Because remember, they're in a 90-degree lateral right now. So first things first, you look at your condyles. If you determine they are not superimposed, there's a couple other things we can look for to help us determine if they're under-rotated or over-rotated. Notice one condyle is sticking more posterior than the other. So I always look at the posterior condyle. What I'm looking for is the presence of the adductor tubercle. And once you label your bones, you'll know that the adductor tubercle is a small bump found on the medial femoral condyle. There is not an adductor tubercle on the lateral femoral condyle. If you see adductor tubercle, you are always under-rotated. And what that means is you need to turn the leg more towards the image receptor. So maybe you turn them 88 degrees instead of 90, okay? Now, there are times where you question yourself, like, is that adductor tubercle? I can't really tell. You know, some people, maybe if they have arthritis or osteoporosis, for example, you really don't see that nice pronounced adductor tubercle. There's another thing you can look for, and it's the relationship between the tib fib. Look at my proximal tib fib. They are very superimposed. That is another indication that the patient is under-rotated. Look at our lateral for a second. In this nice, beautiful, true lateral, look at my tib fib. They're not completely superimposed. There is some separation here. Here, they are totally superimposed. So again, that's my second clue that the patient is under-rotated. To correct this, I need to turn them towards the image receptor more. And this is real slight rotation, you guys. You're just increasing that lateral just a little bit more. And oftentimes what I like to do is, and you'll see this in my positioning videos, I like to get down and look at that patella. And if I picture an imaginary line coming out of my patella, it should be parallel to the floor. That imaginary line coming out of my patella should never intersect with the floor. That's a nice trick to visualize if you're at a 90-degree lateral or not. Okay? Okay, what about an over-rotated knee? Let's look at that. So I take my lateral knee, I'm looking at it, and the first place your eyes should go is the femoral condyles. And I can see here's one condyle, here's another condyle. So my condyles are not superimposed. I have to repeat this. I have to determine, is it under-rotated or over-rotated, so I can correct my positioning before I make my next exposure. Remember, the first thing you do is look at the condyle that's more posterior. Do you see adductor tubercle? If the answer is no, you are likely over-rotated. Remember, if you see adductor tubercle, you're under-rotated. In this case, adductor tubercle, adductor tubercle is right here, but you always evaluate the condyle that's more posterior. Okay, so you look at the posterior condyle, you don't see adductor tubercle, but just to be sure, look at the relationship between the tib-fib. Do you see how they're more separated? There's some separation here. The spacing here is increased, versus this one. Is quite striking difference. If you have separation of the tib-fib, that is another clue that you are over-rotated. So what you need to do is lift that leg slightly away from the image receptor. And it's very slight. Maybe you turned them to 92 degrees instead of 90. So these adjustments are very slight. Okay? Okay, good. Let's look at our next projection. This is a projection of the patella. And remember earlier we talked about you can do a lateral of the patella? Well, this is the other projection that you would do of the patella. And there are 4 different ways to obtain this picture. And we are going to learn and check off on the sunrise method. This is also called the inferior-superior axial projection because we're shooting from the inferior aspect to the superior aspect of the knee. And we're using a tube angle greater than 10 degrees. So that's where axial comes from. Again, because this can be kind of confusing as to which method we're discussing, this is on page 259, specifically figure 6.135. Most commonly at clinicals, you will see the sunrise method or the Merchant's method. So I just want to be clear, we'll talk about all 4 methods in lecture, but for a lab, I want you to focus on the sunrise. So this projection is done tabletop. We do not use a grid for this, and I want you to use a 14 by 17 inch landscape receptor because I want you to include both knees for comparison. You can see this picture is a unilateral knee, and that's just fine, but it's very common practice to include both knees for comparison. So that's how I'd like you to check off. Now, you can use 40 to 45 inches SID. Remember, many clinical sites are still going to use 40, so that's why I put 40 on the slide. I want you to center at the femoral patellar joint space. So all you're doing again is finding the apex of the patella, putting your finger there, and that's where you should center. This time, we are using a 10 to 15 degree cephalic tube angle, and that is from 90. We're starting with a horizontal tube first. So start at 90 and then add 10 to 15 degrees more. So really your tube angle should be between 100 and 105. Okay, so notice the patient's knee is bent about 45 degrees. You don't want to flex the knee any more than that because it can close this joint space. And we'll talk about that more in a second. The patient can hold the receptor for you and make sure you include a marker, but notice this red line here is meant to indicate your crosshairs. So if you're doing bilateral, you would just center in between the legs. This is tabletop, so you're setting your own technique. You're not using AEC. So you'd center, slide this receptor over, include both knees, center in the middle, and then this horizontal line should be at the apex or at the femoral patellar joint space. And I demonstrate this for you in my video. So if this is a little confusing, it'll make sense when you watch my video. How do we know we're correctly positioned in this projection? You want to be able to visualize the intercondylar sulcus. That is this surface of the femur. It's also known as the trochlear groove. And don't be confused because the intercondylar fossa is on the posterior aspect of the femur, and we'll look at that next. So the intercondylar sulcus is anterior, and that is right here. You want to see that very nicely. You also want to see the joint space between the femur and the patella nice and open. And you see that here. Again, if you increase flexion more than 45 degrees, that can narrow that joint space. So that is your patella. Again, the sunrise is very common at clinicals. So a normal knee projection might be, the AP, the obliques, the lateral, and then a lot of doctors like to also include the sunrise. So when you get to your clinical site, you'll learn your knee protocols because they do vary from site to site depending on doctor preference. Okay, last one, let's look at the intercondylar fossa. Remember, the intercondylar fossa is a posterior fossa or groove found in between the femoral condyles. So the intercondylar sulcus is anterior, the intercondylar fossa is posterior. And in this projection, we're really trying to visualize that fossa nice and open. There are 4 different ways to visualize the intercondylar fossa. We are going to check off on the Rosenberg method. Reason being, this projection is most common of what you'll see at clinicals. So everybody that I know, if they're trying to visualize the intercondyloid fossa, they do the Rosenberg method. Again, there are other ways to visualize this, and they're in your textbook, and we'll talk about them more in lecture. This projection can be found on page 251. Notice we are using the Wolbecke. So the patient is upright, and this really helps to visualize the joint space when the body or the legs are bearing weight. That's really what the doctors like to see, is that joint space and that fossa when the patient is weight bearing. Again, I want you to do this 14 by 17 inch landscape, include both knees for comparison. You can do this unilaterally, but most physicians like it bilateral for comparison. You're going to center at the popliteal crease. So when you bend your knee, that's going to be the crease in the back of the knee. And I need you to add a 10-degree caudal tube angle for this projection. Notice the bend here. You want about 45-degree bend. So you have the patient stand PA at the Wolbecke. You have them bend about 40 to 45 degrees until their knees touch the board. And then you have a 10-degree caudal tube angle centered at the popliteal crease. How do we know we're correctly positioned? Well, you want to be able to visualize the tibial plateaus and the knee joint, the joint space, open very nicely. Now notice on this patient, their medial joint space is less than their lateral joint space. And that could be as a result of aging or arthritis. Remember, our medial condyle does sit 5 to 7 degrees lower than our lateral. So some of that narrowing might be just normal. Also, you want to visualize the intercondylar fossa, and that is this tunnel right here. So you really see that tunnel nicely by flexing the knee 45 degrees and adding that 10-degree caudal tube angle. A lot of people call this the tunnel projection for that reason. You see that tunnel very nicely. Okay, and that's it. That's all the 6 projections that I need you to check off on week 16. So remember, the intercondyloid fossa, there are 4 different ways to do this. You need to do the Rosenberg for me when we check off together week 16. Okay, so let's exit right out of here. And let's go back to our Canvas page. Continuing down on our page, you can notice I've provided some practice activities for you. There is a practice lab quiz, and let's just take a quick peek at that. So this is not graded. It's 20 questions. It's not graded. You can see there is point values associated with each question, but it's not graded. I do want you to put in your email address so that I can see that you've completed it, and I can see your correct and incorrect responses in case we need to talk about something again. So I asked you a number of positioning questions, and if we just look at the first question here, It's very important that you are able to identify knee projections based on their written descriptions, because that's how it's going to be on the test. So I give you a written description and ask you to identify the projection. So I ask you a number of those questions, and then I show you some x-rays. So tell me what projection or position this is. And you should be able to look at the relationship between the tib-fib and the position of the patella and tell me which projection or position this is. So I give you all the choices here that we learned in lab this week. Then if we scroll down to the end here, I also labeled some anatomy so you can practice identifying anatomy on your x-ray. So again, I ask you some anatomical or anatomy specific questions. Okay, so that's the first thing I want you to work on. Don't forget, you also have diagrams, you have terminology, you have recorded lectures, you have RadTech Bootcamp, you have the workbook, you have your apps on your iPad. So there's a ton of things you can use to practice with the anatomy this week. Also, week 16, you have a lab quiz. It is approximately 65 questions again, like our last lab quiz. You can work with a partner. Spelling does count again, half a point for spelling errors. And anything we've learned since August is fair game. So anatomy, positioning, and pathology. There will be x-rays and there will be bones. So to practice for that, I have listed some structures that you should be familiar with. So you can practice in lab if you want to get out the bone boxes. Let's just click on one of these here. You can get out the bone boxes and you can practice picking out all these structures. So on a scapula, you should be able to identify all of these structures. Or you can practice this at home using your skeleton or your diagrams or whatever you'd like to do. This is all anatomy that we have learned this semester. So think about how much you've learned. Like your brains are so full, right? For sure. So I think it would be tremendously helpful if you took out your skeleton or the bone boxes in lab and went through and labeled all, or not labeled, but at least be able to pick out all of these parts on a bone. Okay. Now, when you are attending Open Lab, if you have questions about positioning, Zoom with me, call me, text me. I am happy to help, and that's what I'm here for. I will be available week 16 so that we can demonstrate knee, practice knee, and check off on knee all week 16. I want you to use week 15 to get caught up on, shoulder and lower extremity. And some of you have a couple others to do as well. If you have any questions, please let me know. And I hope you have a wonderful week 15. Thank you.